So we'll go ahead and kick it off. Lance, just let me know when you need me to advance the slides and I'll do so. So thank you all for joining us. I think this is going to be a great presentation. I've heard Lance speak before about all the things that they offer at Expect Care, and I was really blown away about what there was to offer and kind of surprised about what I didn't know about hospice. And so I'm really grateful to you, Lance, for taking the time out of your day to come in here and share what you have to share with our caregivers. I really hope that this information is something that they can take home, mull over, see if it's something that fits their needs, and I will reach out for further assistance from you. So without further ado, I'll go ahead and hand it over to you, Lance.
Well, thank you so much. Good afternoon, everyone. Thank you, Jenny, for inviting me to be a part of this conversation today with your caregivers. It is National Hospice and Palliative Care Month. It is a passion of mine. I've been serving in hospice almost 18 years, and it's the best kept secret, I call it. It's the most underutilized medical healthcare service that we have available to us that insurance covers. And I just want to be able to, share the resources, information about hospice, just titled it Hospice 101, but definitely want to get to your questions that you may have, because there's always questions. And I hope some of the discussion, some of the information provided today will make you generate some questions or misinformation that we typically have about hospice, and misconceptions of hospice, that and what we call myths, the myths of a hospice as well. So just want to promote hospice, that we all be hospice and palliative care advocates. We need ambassadors and advocates out there promoting the right information for the right care at the right time for patients who need to utilize their hospice benefit. So with that being said, we'll just start with who we are. I'll then advance in the slide. Expect Care, we are a family and locally owned faith-based hospice serving the greater Birmingham area. We serve 6 counties in central Alabama. We are family owned. There's not many family owned hospices left, especially in the Birmingham area, but thankfully we're still one of them. I've been here almost 7 years, and I love family owned hospices because I believe that we take care of families how we would want to take care of our own families, and there's no corporate structure out west or out up north telling us how to take care of our patients here in the area. And not only that, we pride ourselves in being a faith-based organization. Our owners started Expect Care out of a mission, a calling, a ministry. And we are guided by, the biblical principles of just being the hands and feet of Jesus, showing compassion, providing quality care. And I think, people ask, well, how can you be faith-based? Well, if we're serving our patients and our community and our families as we're serving unto the Lord, we're going to take excellent care of our patients and their families and their needs, doing it, the Christ-like way. So I'm proud of that. I'm proud of our mission. I'm proud of Expect Care and what we're able to accomplish in the greater Birmingham area. So the next slide really answers the question, what is hospice? Hospice is not a 4-letter word. It's not a bad word. It's not a curse word. It's not something to be scared of. I do say hospice is a 4-letter word. The word is hope. That's the word I like to use for hospice. It's hope that I don't have to live in pain with my life-limiting illness. Hope that I get the services and the support I need with my life-limiting illness to stay in my own home as long as possible, supporting my caregivers as well. Hope that I can get equipment, medications, you know, a nurse, a doctor in a timely fashion. Um, and hospice provides all that because we are a specialized form of advanced supportive care for patients with a life-limiting illness. Hospice is a medical benefit that most major, I would say, everyone that has a medical insurance um, has a hospice benefit of some type. Majority of them, I'd say 95% of them do. Every once in a while, with a younger patient who may have Blue Cross or something, they may not have a rider for hospice. But I have a rider for hospice under my insurance under Blue Cross, and I'd say 95 or greater people have a hospice medical benefit. Hospice, our focus is different than home health. If you've ever had an experience with home health, you know a couple things. One is home health goal is rehabilitative. It's to get the patient back to their independence or to where they were functioning before the acute event happened, if all possible. You also know it's typically short term. Home health is usually short term and maybe 6 weeks or less, or you might get an extension if you still qualify for home health. But typically it's 60 days or 6 weeks or less, and the patient meets their goals, and then home health is out of the home. And it's also home health is typically limited. It's limited with in the aspect typically you always get a nurse, a skilled nurse, and then the second thing you normally get with home health is physical therapy. Everybody wants physical therapy. And physical therapy in rehab has its benefits for a patient who can recover. What we see a lot of times in healthcare and with individuals, with patients who have true end-stage disease progression or life-limiting illness or terminal disease, everybody wants to do rehab. That's the first thing the doctor wants to go to is, well, we need to do rehab, we need to do physical therapy. And so it's because it's an easy conversation to have, and and typically families are more receptive to that. They don't want to have doctors do not want to have the conversation with hospice. They usually want the family to bring up hospice because they're uncomfortable because they don't understand it either. They have to attend these lectures or learn about the hospice benefit as well because they're not taught that in school. So they don't like to speak to things that they're unfamiliar with. So that's why we need hospice advocates and ambassadors out there like yourselves sharing the hospice message. But typically, so you have an advanced COPD patient or advanced heart failure patient, and we're giving them rehab, and it's really making them worse and making them weaker and causing them to maybe have an event like a blood pressure dropping or maybe even chest pains or just more shortness of breath. And then you find them from rehab back into the emergency room, back into the hospital setting again, what I call the vicious cycle. So when hospice probably would have been more beneficial of getting the patient home, focusing on comfort, focusing on what we call pain and symptom management of the advancing illness and its progression. So hospice differs in that we are focused on comfort, pain, and symptom management when curative treatment is no longer the goal or no longer able, the patient is no longer able to tolerate those types of curative treatments that are available to them. And so all of our staff, our nurses, our physicians are skilled in pain management and symptom control. And our focus is always on quality of life over the quantity of life. Next. So at Expect Care, as I mentioned, we're family and locally owned, so our patients and families come first. There are a lot of things that we can do at Expect Care that we pride ourselves in, some of our programs, some of the things we can offer our complex patients that maybe other hospices are unwilling to to provide, but we put our patients and families first. We can admit patients with a physician's order and consent from the patient and family same day. We can, my role as a community educator is as simple as it is, educating the community, right, about the hospice benefit, about their options of care for someone who has a chronic or life-limiting illness. But I can meet with patients and families in the hospital. I can meet with them in the nursing home, in a rehab setting, in their own homes. I have those family meetings to discuss, goals of care and the options available to them. But we cannot admit a patient to our services without a physician's order and obviously the consent of the family. And we can do that same day. And the services we provide are always based on the patient and family acuity. So I always tell patients, families, as your loved one's needs increase, our visits increase. And there again, that's how we're different from home health. Home health is, you call the home health nurse or they're in the home, they're going to send you to the ER because they don't have any other safety net, if you will, to help the patient and family through that event. So the beauty of hospice is that as our patients' needs increase, our visits increase. And we can tailor the plan of care to that patient and to the family's needs, because for instance, we had a patient on Thursday or Friday who had a significant change, and our nurse wanted to make daily visits. But the patient was comfortable and palliated well, but we just wanted to be there to support the family through the change. And they were saying, no, that's okay. We've got this. And so while other families maybe say, yes, we want those daily visits. So it's always based on the patient and family's needs and their acuity. Next. So who's appropriate for hospice? Well, as I mentioned, anyone that has a diagnosis of a life-limiting illness or an end-stage disease. The educated guess is if the disease takes its normal course of action, the patient may have 6 months or less. And a lot of people get hung up on this because that is a definition that Medicare gives us that we go by. However, that doesn't mean, the key phrases there is best educated guess if it takes its normal course of action. And every patient's disease progression is different. And so what happens if the patient lives beyond the 6 months? That's okay. We have to recertify them after the 6-month mark. We have to recertify our patients every 60 days. But the beauty of hospice is, as long as we can document the patient's progression, the disease progression, then they can remain on hospice care. And so we've had patients on our services with, say, congestive heart failure or Parkinson's, dementia for almost 12 months or even over, or maybe a year and a half, because they had decided earlier on in with their diagnosis, they want to focus on pain and symptom management instead of curative. And they want to focus on, that supportive care that hospice can give them and keeping them in the home and managing their care and supporting the caregiver. And so we don't really get hung up on this 6 months mark. There are markers, there are signs and different, symptoms of the disease that we're looking for, that our clinicians, our medical director, Dr. Keith Sweats, is looking for. And that includes frequent trips to the hospital, ER. If you have someone that you're caring for that, say, every other month or once a quarter, you find yourselves in a situation where you're in that roller coaster cycle of ER, hospital, admission, rehab, back home with home health, resuming home health, and that those are signs that hospice may be a better support to you, and caring for you, and that your loved one may benefit and qualify. And so we're constantly always reviewing our patients and families to making sure that they qualify. And if our patient at some point stabilizes over a course of months while they're on hospice, we have to discharge them. We may discharge them back to home health if they meet criteria for home health, or whatever the situation is. Our social workers working um, very closely with the family, making sure that they have the support that they need after discharge from hospice. But we do have live discharges from hospice. It is a thing. And a lot of times that happens because when you're on hospice, you get so much more attentive, personalized care that sometimes we could just go into the home and teach the caregiver and family, making sure the patient's wounds are healing, or they're taking their medications right, and sometimes our patients do stabilize, um, and then we have to discharge, and they may later at a later time, months down the road or years down the road, be eligible for hospice again if there's another significant change as well. Next slide. But these are just some examples of types of end-stage diseases that are appropriate for hospice. Again, COPD, heart failure, cardiac, liver, Alzheimer's, or other dementia diagnoses, cancer, any neurological, stroke, renal, and of course there's many others. But the point is when or someone's diagnosed with an end stage or heart failure or those type of diagnoses, they may be eligible for hospice. It's always good to ask, your physician, or call me or call a hospice in your area. If you just call me, I'll help you through those conversations. Even if you live out of the Birmingham area, I want to be a resource to you and connecting you to maybe some resources in your area. But there's just some examples. Next slide. Again, just some ideas of when to refer or when to call us to see if you qualify. There's an overall decline in the physical mental status of a patient. One thing we definitely look for is weight loss. Has there been significant weight loss or just a gradual weight loss over we compare the last 3 to 6 months to a year, what's been going on in that patient's, care. Have they had ER visits or frequent hospitalizations? We look at repeated infections, like pneumonia or UTIs. UTI is a big one, especially those who have dementia or Alzheimer's. But if a patient is on continuous O2, you see someone maybe with heart failure or COPD, maybe they were able to walk to the mailbox to get the mail, and now the last 6 months ago, maybe they can only walk to the front door, and then maybe 3 months ago, now they really can only walk 5 to 10 feet without having to sit down to recover from that event. So that might be someone who could benefit from hospice now. Of course, any chest pain, recurring chest pain, those are some things that we look at. Assistance in ADLs, maybe maybe the patient has to be dressed, to be bathed, no longer can do those types of tasks for themselves, feed themselves, or walk. ambulate themselves. Maybe they need assistance and all of those things. Those are just some things that we look for that in a patient that may be appropriate for hospice health. These are some of your team members, if you're admitted to hospice, who are part of your care team that you will, have contact with. And part of your team is your physician who sends the referral. Also, our medical directors are available. Our in-case managers, you will have a designated nursing team, bather. You automatically get a bather. That's different from home health. Home health, you may or may not get someone to help you with the baths. Home health, you may not qualify for it under home health guidelines, or they may not have the staffing for it. But under hospice care, these are your team members that are part of your plan of care on day one. The CNAs for the bathe, the baths, the showers, social workers get a bad rap because a lot of people think of social workers that all they do is call DHR. Well, we don't want them to call DHR. That's not their role. Their role is to help, again, support the patient and family by finding other resources like Alabama Respite or Middle Alabama Area on Aging or your local Aging and Disability Resource Center in your area. Just finding resources, you're a veteran, VA resources that can help undergird and support the family in the caregiving process. The chaplain and bereavement care coordinator, or the chaplain, is part of your plan of care to focus on the spiritual needs of the patient and family, if you like. And then volunteers. We have volunteers that do all types of things. The primary goal and role of a volunteer is to provide a friendly visit to the patient, while also maybe if a caregiver is involved, giving the caregiver a short respite break as well, maybe a couple hours for the caregiver to run out and just run a few errands, or maybe go do a Bible study, or just go, with lunch with friends. But these are part of your care team under hospice. So on every visit, again, we're evaluating the patient's pain and symptoms of the disease progression. We're managing that effectively. We have scheduled routine visits, but also intermittent visits. We're available 24/7, 7 days a week. And we have an after-hours call center. We become the new 911 for the patient and family. You call, unless there's a fire. If there's a fire, we always want the patients and families to call 911 first and then call us. But anything medical, we become the new 911, because if a patient's family's goal is to, again, manage this disease progression and the symptoms of the patient's experience at home, and to keep them in the home, keeping them out of the ER in the hospital, there are a lot of things that we can do in the home. For instance, God forbid, if our patient has a fall, an unfortunate fall, we can do mobile x-rays in the home, unless there's trauma to the head or visible blood. In those events, we would say, well, let's go to the ER and take care of this need, and let's come back home. We coordinate that with the ER. But otherwise, we can do a lot of things in the home, like the x-rays or a chest x-ray sometimes, especially as we get into the winter seasons with our COPD patients or those who have a compromised respiratory situations. We might do chest x-rays in the home. We've done Dopplers on our heart failure patients that may have blood clots in the leg. There's just a lot of things that we can do in the home. But the beauty, again, is after hours on the weekends, if our patients' families need us, you call us, the nurse comes out to assess the situation. We have 5 medical directors available 24/7, so that our patients are not they'll always get what they need. The nurse is in the home, we're calling our doctor. The doctor immediately is sending, if needed, a prescription, a fax over prescription to your pharmacy, whether it be for pain or antibiotic or Lasix or whatever it might be. We're treating the symptom immediately. And we're aggressively treating that symptom, and we can do that immediately. When you're not on hospice, you know the situation we all have for preventative medicine. We call our doctor, we leave a message, right? We leave a message, and every doctor's office I call, the message usually says, do not leave duplicate messages for it take us longer to get back to you, all those things, but we'll call you back within 24, 48 hours. By the time they call you back, when they call you back, they're going to say, oh, well, I haven't seen you in several weeks or months. I need you to come in the office. Well, that's another week that's gone by. And you needed something for that UTI, or you needed something for that shortness of breath a week ago by the time you actually see your doctor or they call you back. And then you find yourselves in the ER, that cycle again. So that's the beauty of hospice. We stay on top of it immediately during our routine visits or after hour visits. Again, as I said, as the patient's needs increase, our visits increase, the supportive care that you get from hospice when you're dealing with situations with someone that has a life-limiting illness, you just can't beat it, compare it to anything else. Next. Again, the hospice becomes your new 911. I just addressed that. We can go into the next one, I think. Additional benefits of hospice people don't realize is not only do you get the supportive care, the team, focusing on pain and symptom management, all of those things we just mentioned, but under the hospice benefit, hospice begins to provide or supplement some of the needs of the patient. One thing we begin to cover is all the medications related to the hospice diagnosis. For instance, if a patient's on service for heart failure, we're going to cover the heart medications and anything related to pain, sleep, anxiety, depression, any new antibiotic. We start paying for those types of medications. Anything outside of that, the normal insurance will pay, and if there's copays for those, then you pay those that are not related to the hospice diagnosis, as you always have. But there are no copays for anything hospice provides, any of our services or medications or supplies. There's no copays for hospice care. Another thing we start to cover and supplement is the disposable supplies like the chucks, the briefs, the pens, whatever the patient is utilizing at the time, the gloves for the caregiver, those types of things. We start supplementing, providing those things in the home. Medical equipment is huge. If you're not on hospice, sometimes it takes forever for your insurance to approve for a hospital bed or for oxygen, whatever it may be. But immediately on day one of admission, whatever our patient and family needs for medical equipment, and in days beyond admission, we order immediately and we get into the home same day. There's no, again, waiting period for anything. Next. There are 5 levels of hospice care. Some of you are probably familiar with the routine home care. Routine home care is what I've really been describing, or you may have had an experience with, or know someone receiving the routine home care where they're getting routine visits from their care team. But there are other actual levels of care. So if we're in a situation in a home under routine home care, say a patient who has advanced cancer and they have, their nausea and vomiting, with the medications we have in place is not working, the medical intervention that we have is not working at time, we can move into the next level of care, which is called continuous or crisis care, continuous care, where our nurse can stay in the home at bedside as long as needed, managing that symptom, whether it takes 8 hours or 8 days, until we get that symptom under control. Once we get that symptom under control, then we revert back to routine home care. If we're in a situation where crisis care does not is not being helpful, or we're still not managing that symptom, then we can go into an inpatient care where we have contracts with some of our local hospitals in the Birmingham area and maybe a couple of our nursing homes where they have a 24/7 nurse. And but typically it's being provided in a hospital setting. For instance, UAB Palliative Care Unit, we have a contract with them. Our lead medical director, Dr. Keith Sweats, is a UAB Palliative physician. So we have a good relationship with UAB Palliative Care. So we would utilize UAB Palliative Care Unit to to help under general inpatient hospice care, where we go to that institutionalized setting where we have more access, can gain access to more what we call aggressive, comforting medical treatments there on the unit. But again, it's still short term. We want to get that symptom under control and get the patient back home to routine home care. And then one major level of care that really sets hospice apart from any other medical provision is respite care. Currently, this is the only way that insurance pays, major medical insurance pays for respite care is through the hospice benefit, where this is strictly for the caregiver. Caregiving, as y'all know, being caregivers yourselves, is overwhelming at times. It's just too much to handle, and so we've got to take care of our caregivers, give them a lifeline, help them rejuvenate. And what we do through respite care is we relocate the patient to one of our contracted skilled nursing facilities, and hospice pays for the first 5 nights, 6-day stay for the loved one, the patient. We pay for that. Nothing changes with our care. Matter of fact, we're visiting daily on our patients who are in respite care. So we increase the visits because you want, obviously make sure our patients are staying comfortable and palliated and taken care of. But it gives that caregiver a short break. Sometimes our families may pay for to extend those 5 nights if they go out on a longer vacation with maybe their own children or grandchildren. But we are able to utilize that. For expect care, we allow our caregivers maybe to utilize that every 30, 60 days, unless our caregiver is experiencing an emergency, we can utilize that at any time. And then the last level of care is bereavement support, bereavement services. So obviously this is after the time of the patient's passing. We differentiate between the disease progression, which could take, depending on when they elect their hospice benefit, it could take weeks or maybe months, but at the point where they transition to what we call the actively dying stages, which unfortunately is what most people think of hospice, because they waited too late to utilize hospice, or the doctors have waited too late to refer to hospice because they think of hospice as only the last final days. We do prepare the patient and family for that event, but really, and you're not getting the full benefit of hospice if you're only utilizing hospice for a few days or the last week. It's really designed for 6 months or to a year, or longer, again, depending on the patient's disease progression, but to really get the full benefit of hospice. But however, when our patient does pass, our bereavement support begins for the caregiver or anyone in the family to help walk alongside of them over the next year, 13 months or so, to support them through their grief journey. And that's to me another beauty of hospice, is because I've had my dad was on hospice for about a year with a hospice up in North Alabama. And then my mom had something acute, some sudden change in her condition, and she died in the hospital. We did not have bereavement support. And And that's generally what happens, unfortunately, when a patient passes in, say, a nursing home setting or a hospital setting or any setting without hospice. Typically, the only uh, time we hear back from those facilities is really about the bill, unfortunately. Um, I jokingly, not jokingly, but there was a time where I needed someone to talk to after my mom's passing, and I was like, "Where's my hospice?" My bereavement support. But of course, I have that here at Expect Care and through our chaplains and through our bereavement coordinator, Carrie. Um, but it's part of our ministry. We invest in our bereavement ministry here. We have memorial services at our office. We have a volunteer who makes memory bears out of our loved ones' clothing that we present back to the family. There's just a lot of one-on-one or group support. We have a grief support group that meets here at our office. So there's just a lot of support that can be gained by someone utilizing their hospice bereavement services. So those are the 5 levels of care, and it's all covered under the hospice benefit that we all have when we should need it when we're caring for someone with a life-limiting, difficult illness. And I think, at this point, I want to open up the question. I know there's more on the slides, but it was just describing each of these levels of care. So as far as hospice and what we can provide and the services and what we cover and the supportive care it is, I think these slides and this information hopefully is helpful to you all. My number is going to be at the last page there. Feel free to, I want to answer your questions now, but anytime after this conversation, if you have any questions or concerns, or if I can connect you to other resources, that's my role. That's what I enjoy doing, to helping caregivers. And you're welcome to call me anytime, text me, call me anytime, 24/7. I want to be available to you all. So, but what kind of questions do you all have? Or
All right, thank you so much, Lance, for that description of the services Expect Care provides. I'm just looking through the chat here to see if there's any questions. I don't see any questions in the chat, so if anybody has any questions for Lance, feel free to unmute and just ask him now while we got him on the line. We've got plenty of time.
Okay, thank you, Jenny. This is Lolita. I appreciate you for coming on, Lance. You gave us a really good working definition of hospice, and I was just thinking it's just like almost immediate when your caregiver is about to expire. But you said that you all respond just like 911, and with our mom, we've had to call. I don't know, sometimes 2 to 3 times a year, depending on what's going on with her. So you all respond within the 2 to 3 minutes?
so obviously we would not be in the home in 2 to 3 minutes. However, so we have full-time nurses on call 24/7. So after hours, so what would happen is if there's a significant change or if there's a issue that our family or patient is having after hours, then the on-call nurse, you get the on-call nurse immediately that you're calling, and they're going to help you through that event, say, and they're going to be en route. We're typically to the home, I would say within the hour. But if our patients and families, at the end of the day, I always say our patients and families, you are the boss. You are your own advocate. And if you want to go to the ER, that is your choice. All of the treatment and I guess interventions that we will do is to keep you out of the ER. Because we're focused on comfort and pain and symptom management. So we're going to do that in the home if all possible. So our nurse is going to guide you, guide the caregiver, guide the person who is caring for the patient they may say, hey, make sure their oxygen's on, give them some medicine, give them XYZ medicine, I'm on my way. And then they're en route to your home. And typically they're in there, depending on the travel time and where you live, they're there within the hour. And then they'll help address any needs or any changes to the plan of care. If we need to change medications or get something, supplies, or get equipment in the home, then they're calling our doctor and we're treating that on the spot. Or if it's an x-ray, we can get an x-ray, they'll call the x-ray, whatever, to come to the home.
Okay, great. Thank you.
Mhm.
Are there any other questions for Lance? I'll go ahead and share again your contact information. Let me get my computer working. There we go. So as Lance said before, he's open to you all contacting him after this presentation if you need any specific questions answered that you don't feel comfortable asking in front of everybody. I totally get that. So I appreciate you, Lance, making yourself available not only for this training, but also for extended care and resources for our caregivers today. We had a lot of people show up, and I'm really excited that we were able to have this time to get this I don't know, just kind of like demystifying the hospice experience. I think it's very easy for us to kind of have an idea in our minds of what it is, and then it's just, I really appreciate you coming and shedding some light on what it truly is, and I hope that everyone here today feels confident in seeking out hospice care when that time comes, and maybe not waiting too long to do so. Like you said, they're not getting their full benefits if you're waiting till the last week or so. So thank you again, Lance. And I don't want to rush anybody off. If anybody came up with any other questions, I'll give you time to do that. But in the meantime, if you have not signed up, but if you have not yet put your email in the chat, please do so now so we can get that post survey to you and you can get that education stipend. And also I welcome your feedback as always for these trainings, because they are for you and I like to design them for your needs. So if there's not any other questions, I'll go ahead and end the chat, but I'll just give a few more minutes just in case. All right.
Well, thank you again for allowing me to share with you all. And again, please, as Jenny said, take my number. I want to be a resource. That's my passion, is walking alongside caregivers, helping them navigate all of these options that are available to you as a caregiver in our community and in the state and wherever. So I hope that was helpful information. The best advocate for you is the best advocate is you. You have to ask, you have to advocate for your loved one in all situations. So, but I want to be another advocate for you, whatever I could do to help.
Yes. All right, and Lolita says, very informative, Lance, thank you. And I agree, very, very informative. So again, thank you so much for your time, Lance. I appreciate it. And you have a good rest of your week. Everybody else have a good rest of your week as well. Don't forget, we do have a lot of education coming down the pipeline for y'all next month. We also have the caregiver support group coming up as well. So feel free to get on our website and register for that if you're interested in joining us. Everyone take care of yourselves. Get your rest, drink your water, eat your fruits and veggies. And we'll see you all next time. Thank you again. Bye-bye.